RetinaRounds, podcast number 2. In today's podcast, Stephen Schwartz interviews George Williams, a pioneer in private practice academic leadership. Dr. Williams is past president of the American Academy of Ophthalmology and is chair of the Department of Ophthalmology and director of the world-famous Beaumont Eye Institute in Royal Oak, Michigan. In this interview, Dr. Williams discusses the importance of the people who surround us in our professional lives, recounting his path in ophthalmology, the professional relationships that have enriched his career, and the qualities he values in both colleagues and trainees. It's an enlightening discussion on the interpersonal side of ophthalmology from a true giant in our field. Let's check it out.
Well, good afternoon. We're here with George Williams as part of our Giants in Retina series. It's really a pleasure to have you with us, George. Thank you so much for joining.
That's my privilege, Steve. Thank you.
Thank you. And so for our audience, which is global, I'm going to ask you to introduce yourself. For those of you who don't know, George is one of the founding partners of Associated Retinal Consultants in Royal Oak, Michigan. He is a true giant in retina with massive contributions both in surgical and medical retina, and has pioneered what is really the flagship academic private practice in the world. Their practice has a global footprint, not only through their participation in international professional societies and meetings, but also training some of the world leaders and fellows, both domestic and international, and really setting the tone for what is a self-motivated academic proclivity to move the field forward. So with that, George, maybe you can describe to us your early days in there in the Detroit area and how you landed in Detroit.
Well, thanks, Steve. Well, I was very fortunate to end up in Detroit. Like many of us, after completion of my fellowship, I went into full-time academics. And I had the privilege of working with some true giants in our field at the Medical College of Wisconsin in Milwaukee. So I had the privilege of being trained by Tom Aubert, Gary Abrams, and Trex Topping, among others. And it was really at the time in the late 70s to early 80s when vitreoretinal surgery was literally exploding. So during that time, during my fellowship, we had the advent of, for example, endophotocoagulation. Now we all kind of think of that it's been around forever, but no, it really hasn't. So the development of the technology that would allow us to actually take a laser probe and put it in the eye is relatively recent, and it started in the late 70s and early 80s. And the guy who really pushed that, got that going, was Jay Fleischman. Jay was a fellow at the time in Milwaukee, and Jay was also a student of laser technology. He had an engineering background, and he saw the potential for photocoagulation intraoperatively. So before that, basically, we did have a photocoagulator, but it was not a laser. It was essentially it was a xenon arc, and to say it was cumbersome would be kind, but we could sometimes treat the retina with that. But it was really Jay's contributions and his friend Mano Schwartz in Utah, who saw the technology that was actually being developed for OBGYN to be able to treat gynecologic lesions with, at the time, a very powerful laser. And Jay immediately saw the potential applicability of that laser in ophthalmology and developed the first technology that we were able to demo, and then it's been further refined, and it was really a game changer for us during that period of time. At the same time, we started to see improvements in techniques for retinal dissection. So initially it was all unimanual, put a 20 gauge cutter in there, kind of go around and try and cut what you could and relieve traction. But we really didn't have the bimanual facility that we have now. And so that technology was also developed in Milwaukee, not exclusively in Milwaukee, but Milwaukee was one of the leaders with the development of illuminated probes and picks to allow us to operate bimanually. And Gary Abrams popularized the concept of an en-bloc dissection. And by that, he meant removing the entire neovascular complex if possible. Before that, we were doing segmentation. So we would do a vitrectomy, and then we'd address the fibroproliferative disease in diabetes predominantly by sectioning the membranes and leaving fairly substantial chunks. But if we relieve the traction, that was often successful. And Gary and Tom Aubert were among the first people to recognize the benefits of removing as much of that proliferative tissue as possible. So it was a very exciting time to be in Milwaukee. And then as this happens, life goes on, and I had the opportunity to join my good friend Mark Blumenkrantz in Detroit. Mark had been one of the first academic leaders to leave an academic medical center. He was at Bascom Palmer at the time, and he left to join the Detroit group. And I recall a nice dinner with a couple of drinks and him convincing me to come to Detroit. It was the best thing that ever happened to me professionally. I've never looked back. And so that's how I got to Detroit.
So for those of you who aren't familiar, Wisconsin really was an epicenter of innovation at the time. And as you came out of fellowship, what were you looking for in the characteristics and qualities of a practice when you were joining a practice? What was it besides the charisma and magnetism of Mark, and of course Mort Cox and others there? What was it that drew you to that group?
I think it was exactly that. It was the people. The fact that we had individuals who all had a prior experience in academic medicine, and yet wanted some control over their lives. One of the downsides of academics is the constant evolution that occurs in the academic hierarchy. So at some point in your life, you work for the dean, and then you have a chair who works for the dean, and then you have a chief of your service, and you work for them. And there's this natural turnover in academics, and there's nothing wrong with that. But it often means that the people that you first hitch your wagon to are not the people you're going to be with 5, 10 years later. And so when I had the opportunity to speak with Mark and meet Mort Cox, who had previously been the retina surgeon at the University of Michigan, and then this fellow by the name of Mike Tracy, who went on to do a few good things, it was clear that it was a group of people who were very serious about advancing the profession. And yet they wanted to do so in a model where they had more control. Our founding partner, Ray Margera, used to say, do we make mistakes? We make more mistakes than anybody, but at least there are mistakes, and we're able to fix them quickly once we realize that we've made those mistakes. And Ray was really the guy who built the practice, and bringing in Mort and Mark and Michael. And I recall one time someone asking him, Ray, how do you do this? How do you get these guys to leave academics, and how do you build such a great practice? And he says, it's simple. I only hire people smarter than I am. And I think that was not necessarily true, because Ray was a very bright guy. But that's the way he felt. He always wanted to bring people to the group that brought something more. And I think that's been the secret to our success.
You and I have sat on a number of panels and talked about how fellows coming out of training or even residents coming out of training should shop for their jobs. And you made a comment, this was years ago, about how hard it is to change the culture of a place you're going to. And I wonder if you could comment about how to search for a cultural fit.
Yeah, I think that's exactly right. The first thing is you need to know what culture you're going to be compatible with. The biggest mistake I've seen over the past 40 years now of training fellows is when someone says, well, it's not exactly what I want, but I think I can make it work, and I think I can change them to do this or that, whatever they're not happy about. And that almost never happens. Uh, you cannot realistically expect to change culture. But that does not mean there's only one right culture. There are many successful cultures. And the trick is to figure out which culture you're going to be most compatible with. So that culture could be the classic academic model. And that's a great culture and it works well for a lot of people. But you have to be comfortable in that culture. It can be a culture like ours, which is a blend of academics and private practice. It can be just a pure work hard, private practice, high volume, take great care of patients, and never write a paper in your life. And that's a great culture too. There's nothing wrong with maintaining a focus of taking great care of patients. But some people are not going to be happy in that culture, and some people are not going to be happy in the academic culture. So the trick is to figure out which culture you are compatible with and not to get caught up in labels. So if you're interested in academics, another thing that Mark taught me is academics is not an address. It's a state of mind. So you can be as academic as you wish and not work for a university, not be at a big academic center. And if you look at the history of Retina, some of our greatest contributors were not full-time academicians. If you go back and look at, for example, macular hole surgery, that didn't come from a university. That came from two smart guys in private practice who said, well, we fix holes elsewhere in the retina. Why can't we fix a hole in the macula? And they took a lot of heat for that. Doctors Wendell and Kelly. Initially, they took a lot of heat. But that's the great thing about science. The truth comes out. And when you're right, and everybody starts to confirm your work. And I think there's little that's more professionally fulfilling than to make a contribution like that and then to then see your colleagues confirm that you were right.
Absolutely right. And can you speak to what practical steps your practice has taken to maintain the culture of academia, full well understanding that you're exactly right. The four walls around you are not the reason that you're academic. It's the four walls around your noggin that make you academic. But what is it? What are the steps that you at Royal Oak have associated retinal consultants have employed over the years to maintain this culture of academia?
Well, I think the first thing is choose wisely. So I identify people that you know well. So that may be someone that you've trained, who's demonstrated to you that you have that they have the same values and culture that you have. The other is to have the opportunity to get to know people practicing elsewhere and talk with them about how your practice runs. And when you hear that they might be interested in something, you might invite them up for a dinner and have a nice chat. But again, it's all about making sure that you're hiring people that share the same values, interests, and culture that you have. Have we ever made mistakes? Not many. But yeah, The bigger
You
your
made
practice,
you made a mistake with me, but other than that,
well, no, you turned us down.
yeah. Well, no, but I came for a few months.
The, it's the nice thing about what we do in Retina is that there are so many successful cultures and so many opportunities to do what we do for patients.
So let's drill on this for a while. I really like this idea of choosing colleagues. How do you choose a fellow? What do you guys look for in a fellow? I granted you're no longer the fellowship director, but and Tamara does such a great job, and you have such great fellows coming out of there with Michael's Award winners all the time. What do you look for in a fellow? What's your secret sauce at Royal Oak?
Well, I think we want someone who wants to do something more than just be a good doctor. We want people who are going to contribute to the profession. And the way we identify those folks is not through their 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 CV or their academic pedigree, where they trained. And it's really through their letters of recommendation from people that I know and respect. And so I know if I get a letter from someone uh, that they're going to be honest with me. They're not going to jeopardize their friendship with me any more than I would jeopardize my friendship with them over a candidate that I was not enthusiastic about. But I've got more than a handful of friends around the country. If I get a letter from them saying, or most of the time it's going to be a phone call saying this is somebody you really need to take a close look at, then I'm particularly interested.
Yeah, one of my great regrets is calling you about Kim Drenzer because I wanted to keep her. And of course, she trained with you and stayed with you, and she's made such huge contributions. And I think you made the same mistake back with Adam, but I think you got him back now. So yeah, we've
Yeah, we
had,
did. No, you're exactly right. And no, you can't have Kim back.
yeah, well, but I'm so proud of both of them and all the other people we've shared. So that's really interesting. And then you were touching on how you advise your fellows about how to join, where they're going to go. I think this is really a universal issue, not just in the United States, but everywhere. And this issue of culture, is there a way that you suggest to the fellows that they can diligence the culture of the places that they're thinking about joining?
I think you have to go visit a place. You have to be willing to spend a little time there. And then you have to look at that particular practice's or institution's track record. If everybody or if the vast majority of folks leave after 2 to 3 to 5 years, that tells you something. Why are people not willing to stay? Is it because of the structure? Is it because of the finances? Is it just because of the culture? So I think that's important. And I tell my folks it's important to talk to the people that are in a practice. It's also important to talk to the people who left the practice. And sometimes you'll find it was, my wife or my husband just had to get back home. His parents are sick. We decided that, Detroit in February just ain't our place, and that we wanted to get back home. And there's nothing wrong with that. So the fact that there is some turnover, that's not necessarily a black mark. But if there's consistent turnover, then I think that raises some questions. You want to get some answers.
Right. We find that a lot of young people really are driven by geography, and the culture of generations changes in terms of work that you're paid for and you're not paid for. I think one of the great things about your practice is you train leaders, and whether they're leaders in organized medicine, or they're leaders in science, or they're leaders in clinical medicine, or practice structure, even local leadership. You train leaders, and that's great. And I think also For the audience, George, you tell us a little bit about your childhood. You grew up in Chicago, I recall, and so Midwest, Milwaukee Midwest, Detroit Midwest. You're lucky because you've found leadership and excellence in your geographic area. Tell us about your how you landed in ophthalmology.
Well, I'm one of those Midwesterners that was just never smart enough to leave. So, things like weather and mountains and all the cool stuff in the world. I love it, but I'm kind of a family guy. My wife's a family person. We wanted to hang around the Midwest because that's where all our family is. Um, when I finally had to I say when you're training, eventually you run out of places to hide. There's only so many fellowships you can do, and you got to make that decision. And when I was looking for jobs, I looked around the country at some very well-known places, but I ended up saying, I really kind of like Milwaukee. I love the people that were there at the time. I said it would be a privilege to be able to stay there, and so that's why I took that first job. And then so I was again only 90 miles from my family in Chicago. And then when we moved to Detroit, my wife is from Western Michigan, so we're only a couple hours from there. And they've got almost hourly flights between Detroit and Chicago, so I could get back home when my folks were still around. So it just worked out great.
Oh, that's fantastic. Now, your practice has one of the biggest international footprints of any group, academic or otherwise, in the United States. In other words, you, Mike, Tarek Hassan, Tamer, Kim, Tony Capone, these are names that resonate globally. And we have a large global audience. So I'd like you to comment as we start this conversation about the excellence of global retina, what motivated you guys besides the fun of travel and new friendships, which I know is non-trivial, the friendship part in particular, colleagues. What motivated you guys to step out and establish that global footprint?
Well, I think it's just the opportunity to see what others are doing. If you look at the international contributions in our field that have come from outside the United States, you can make an argument that the founder of modern day retina was Charles Scapens, a Belgian immigrant. Certainly, the father of modern vitreoretinal surgery, Dr. Makamer, was a German immigrant. And so the opportunity to go to places like Moorfields in London, to go to Germany, to go to Italy, to go to France and see what those folks are doing. They're brilliant people making great contributions. And I think when the day comes that you think you know it all is probably the day that you need to hang it up,
That's
because
right.
there's a lot of smart people in this world that you can learn from. And then you factor in the fun of being able to travel the world. Some of my the best times I've ever had were like going to visit Yasuo Tano in Japan, going to visit Klaus Eckhart in Frankfurt, Bill Aylward and his team at Moorfields, a place you know well. It's really pretty cool to see how the world functions, and what do all those people have in common? They're trying to do the best thing they can for their patients.
That's right. And you're really to be applauded for your open-mindedness and acceptance of all of that. And really, we don't have a choice. If we want to ride the wave of moving the field forward, we have to communicate. And so in fact, I think back, and you and I have been together, whether it's Brazil, Argentina, Central America, Mexico, Tokyo, Singapore. We've been so lucky to be so many places together, all over Europe and the Middle East, and India, and it's just I don't think, at least from my perspective, that I can say that one type of innovation comes from a particular place. I think what happens is the innovators rise to the top. And for me, one of the things I appreciate most about traveling internationally is how hungry the population of retina docs are to learn and to improve. And it's almost, they have a sort of older school respect for symposia and sharing than we almost have here in the States now. It's gotten so hard economically here for so many. It's hard to take time off from work and just go to a meeting for the sake of learning. Whereas in these other places, the meetings are extraordinarily well attended and there's a uh, an openness. Can you comment on that observation?
Oh, I would totally agree with you. One of the most fun things I get to do is I serve as an associate editor of Retina. And my good friend Sandy Brucker gave me that opportunity about 15 years or so ago to be the associate editor for surgical techniques. So I get to see papers literally from all over the world. I reviewed half a dozen manuscripts last night, actually, and only one was from the United States, and they were all insightful, and I think valuable contributions. Some of them were just little tweaks on techniques, but a couple of really good ideas. And I recall the last review I wrote to Sandy last night before I went to sleep was, how come I didn't think of this? Because it was such an apparent good idea. And I read the manuscript and I said, geez, I've been managing these patients for 20 years. How come I didn't think of this?
Yeah,
So
isn't that great?
that's pretty cool.
Well, that's a section of Retina that we love, and another example of how you're involved in academic activities, journal editing, so important. Let's talk about, we'll come back to the current innovations that you're learning about now. Let's talk about innovations in Retina over, say, the last 10 to 20 years. What are the big ones that you think about that have really foundationally changed what we do? The obvious one being pharmacology.
Yeah. Uh, Anti-VEGFs changed the world. I think I can make a pretty compelling argument that there are few drugs across the history of medicine that have been of a greater benefit to people's quality of life than anti-VEGFs. So prior to anti-VEGFs, the management of neovascular AMD, we tried a lot of things. We did lasers, we tried PDT, but at the end of the day, the
Surgery.
man,
You and I tried surgery. We were at
oh
the
yeah,
spectacular
yeah,
surgery trials together in the 90s.
we were. And at the end of the day, the the management was a pat on the back and saying you're sorry because you couldn't really make a difference for the vast majority of those patients. Yeah, we did translocations, we did subretinal surgery, but all of that was a step toward toward the progress that we've made now. Um, the anti-VEGFs when they came on board, uh, it's starting with we started with interferon. Just the concept that we would be injecting a drug that could change the biology of a chronic disease. And did it work? Yeah, it actually did work a little bit, not great. But then David Geyer and his team, and you were part of that, they said, okay, there's this stuff called VEGF. Tony Adamus was one of the world's experts. There was a guy by the name of Ferrara who was pretty big too. But they said, what if we found a drug that could block VEGF? None of us even knew what the hell VEGF was. But those guys had the insight. They came out with Macugen, and it was a great first step. And then science did what science always does. It finds a better mousetrap. And so the better mousetrap came along, and we really haven't looked back. But if you look at that was such a a seminal breakthrough. And, all that happened in 2005, 2006. And now here we are almost 20 years later, and we have great drugs, but not that much greater than what we had in 2005 and 2006. So, but I still think that if you look at the effect on quality of life, our group published a paper of what we called the centurions. These were individuals that had received over 100 anti-VEGF injections. Think about that. That's pretty damn remarkable that we have a treatment where people are getting more than 100 injections. And half of them were still seeing 20/40.
Yeah. Well, the reason they're still seeing 20/40 is because they're still getting injections. But
Yes.
that's another discussion. That's exactly right. And one important point, I gave that first paper on human anti-VEGF injections, the first patient at ARVO in 1999, an abstract. And it took years, 2, 3, 4, 5 years before the real results started coming in. And when we gave that first paper, I gave that first paper, I was lambasted for that. The scientists were saying, 20%, 27% of patients getting a 3-line gain over a month or two, it means nothing. And we would say, you're right, but it's the first time we've ever seen the curve going up. And so it's important for people to keep that in perspective as they innovate new treatments now, whether they're pharmacological or surgical. And George, I know you can comment on a bunch of surgical techniques that when they started, when we were doing them at the beginning, the results were not great. And now they're de rigueur. People do exceptionally well with these surgeries, whether it's PVR surgery or whatever example you choose to take. But give us some perspective on the amount of time it takes to innovate and bring patients along so that we can help them as a population.
Well, I think one thing I've learned over the years is that the more, not always, but the more critical the establishment is of a new technology, the more I'm interested. Because when everybody tells you you're wrong, then I'm thinking, well, maybe they're onto something.
Yeah.
So I can think of multiple examples of that. We already touched on macular hole surgery. Certainly the academic establishment thought that was nonsense because we all knew that the retina couldn't heal.
Right.
And when you know something and something comes along that is antithetical to what you know is true, then it can't be right.
Right.
Well, it turns out we didn't really know that much about how the retina heals, and frankly, we still don't.
That's right.
Maybe we'll touch on that a little bit later.
Yeah, that's right. Well, we've got, your practice has made two huge innovations. Tamer with his transplants into the or grafts into the macula, and Mike, Tracy, and Tony and Kim with the pediatric surgery. I mean, you and I had to massage Mike as he wobbled back into the corner of the boxing ring after getting beaten up for operating on kids for a good 15 or 20 years. And now pediatric retina is in a completely new era. And we have to credit your group for a big part of that.
Well, I think we have to credit Mike for it. I mean, he was the guy who was willing to take on those kids. I mean, just think of that. Those are his genius was not that he was a better surgeon than anybody else. His genius was the realization that you needed to forget everything you knew about adult retinal detachment. So the idea that you must relieve all the traction, that's really the fundamental tenet of adult retinal surgery. And yet, that's why we were always failing in pediatric surgery, because we felt like we had to peel these unpeelable membranes. And Mike was the guy who realized that it wasn't the retina, it was the vitreous. And if you remove the vitreous in the right way and you relieve those traction forces, the retina would reattach itself. And you're right, he would present those results at meetings, and highly respected people would kind of snicker in the audience and say, what a crock. There's no way. I've done 50 of these. None of them worked. Well, that's right. None of them worked because you were doing the wrong operation. And that was Michael's genius. And once he started teaching people, and it gets back to that thrill of confirmation. Once people realized what he was doing and they started doing it, and they said, "Oh my God, this guy's right. It does work." A stage 4 detachment, you relieve detraction, the retina reattaches, and that's the child that will see for the rest of their life.
Yeah, it chokes me up to think about it. It also puts a smile on my face because I loved firing back at his critics together with you, often as we were walking away with our arms around him. But I think you're exactly right. That was his genius. But another part of his genius was how prepared he was academically. Michael read everything that had ever been written on the topic. He went and talked to everyone who was alive who had anything to do with this. He left no stone unturned. So he had zero element of being cavalier about the privilege of intervening at this critical moment in people's lives. He never lost sight of the fact that these are human beings, even though they weigh less than, a steak. And just remarkable preparation, academic preparation, compassion went into this. So there should be no takeaway to those people listening that he just had a concept and started trying something on people. He prepped like crazy. Maybe you could just talk about his commitment to learning about this and bringing it forward
Well,
incrementally.
yeah, Michael was a true clinician scientist. He was trained in pathology by Bob Foose. So he always wanted to understand the mechanisms of disease. Um, and he took that approach. He felt that if he understood the mechanisms and the pathogenesis, then he could come up with a treatment. So he tried that. We tried it with the advent of plasma. He recognized that one of the biggest problems in pediatric retinal surgery was the adhesion of the vitreous to the retina in children. So I had done some work with tissue plasminogen activator when I was in Milwaukee, and when I came to Detroit, he was just starting to take on these very complex pediatric detachments. And we started talking, and he said, "Well, there may be a way that we can dissolve the vitreous." That's how simplistic we thought. So we developed autologous plasma, which eventually became the first approved, still the only approved vitreolytic. Now, did it work as well as we had hoped? No. But there's that opportunity. So someone else can develop a better mousetrap, and I still think that vitreolysis has some potential. We just gotta find a more effective agent to dissolve that vitreoretinal interface and do it without damage to the retina. But he was always looking for a way to do something better.
When you apply the standards of your partners and the people in the world that you respect, what sort of advice do you give? You have a lot of trainees coming through your world. What sort of advice do you give to the residents, medical students, and fellows at your university in terms of their learning programs and what they should be concentrating on? We see and have seen over the years, maybe appropriate, maybe inappropriate, focus on surgical volume all the time. What do you tell people that they should be doing? Is it reading programs or conference programs? How do you coach and shape leaders?
Well, I think that's one of the things I'm most proud of. I recall being at a meeting when I was very junior faculty back in Milwaukee, and someone came up to Tom Auberg and said, "Tom, you've had this incredible career. What are you most proud of?" And he didn't even blink. He said, "The fellows." I thought, wow, this guy's most proud of his fellows. Then I started looking at the people who were his fellows and the contributions that they were making. And I understood exactly what he meant. And I would say that there are a few things that bring a bigger smile to my face than to go to a meeting and see one of my fellows, ex-fellows, running the panel or presenting the latest in whatever surgical technique or new drugs are out there. Because that's exactly what you hope as an educator. You hope you're training people smarter than you and that they will make contributions to the field.
What sort of disciplined algorithms do you have them participate in while they're training in terms of reading, specifically conference attendance? How do you manage that at a granular level, or do you?
I don't think I really do. I think the key is to everyone learns differently. So I think the key is to find people who are self-motivated and just let them do what's made them successful. And the harsh reality is you have to have done pretty well to get into a vitreoretinal fellowship, any vitreoretinal fellowship. And so these are people that are accomplished already. And in order to get them to the next level, sometimes all you have to do is just get out of their way. Now you want to show them things the way you think they can be done and should be done. But at the end of the day, they've got to figure it out for themselves. So as far as do we have a prescribed reading program? No, we do have a weekly meeting where all the fellows get together with the faculty and we present interesting cases. And we hear how Tarek wants to do it. And then Tony says, well, yeah, but if you do it this way, it's a little better. And then Tamara says, well, at Duke, we used to do it this way. And that's really how you grow. I think one of the risks of programs is they become too self-isolated. So in our place, nobody does anything the same way. And I think that's what makes our fellows better because they get to pick and choose. There is no one way to even put a buckle on an eye in our place. And so no one leaves our program, a clone of Tony or Tarek or me. I like to think that they can pick and choose whatever techniques work best in their hands for them, and then they can go out and develop it. And I often say no one leaves their fellowship a great surgeon. There's a seasoning process that occurs in all of us. And I think that takes at least a few years of getting that volume, of getting your nose punched more than once and say, okay, I'm not going to do that again. And just to see, just to gain that experience, that's what distinguishes a surgeon from a technician.
That's right. And that's the reason why Pradeep Prasad put together RetinaRounds with these surgical cases every day and everyone doing things, the same things in different ways, because we want to democratize the sharing of information and bring the surgical rounds that are a feature of the ARC fellowship, the feature of the fellows that we've trained at UCLA. We want to bring that everyone does something differently to the world and democratize the discourse, and hopefully that will do it. Certainly, Uday Devgan's done that with Cataract Coach, and we're trying hard to do that with RetinaRounds.
I think it's a great idea, and I'm privileged to have the opportunity to participate.
We're really thrilled. Before I let you go, I wanted to get your perspective and have you share it with us on organized medicine. You've been a huge contributor and leader in organized medicine, whether it's the Macular Society, the Retina Society, but most of all, the American Academy of Ophthalmology and your work together with David Park and Bill Rich and interfacing with our government. But start with internationally, the importance of being involved. I know you've had lots of interactions with people who are leaders in their countries or their regions in terms of organized medicine. So start with the international picture and why it's important to be in organized medicine, and then bring it back to national and then local, if you can.
Sure. Well, I think that regardless of where you live, healthcare is becoming an increasingly important component of the economy, of the government, and frankly, of simple quality of life. At the end of the day, we all just want to, despite all the craziness that's going on in the world, I think we all just want to have a good quality of life. We know people are going to get sick, and as physicians, it's our job to try and minimize that disease burden. So it's been a great privilege to me to be part of international societies such as the Club Jules Gonan, the Asia Pacific Academy of Ophthalmology, the PAAO. And when you go to these international organizations and you speak to their leaders, they're struggling with the same issues that we are. How does their government finance healthcare? And it's the issues are always the same. The solutions are never the same. So you look at England, United Kingdom, brilliant people, international leaders across all the specialties. Yet their system's really struggling now. And it's struggling. The NHS has been one of their government's crown jewels. But the
It's never been the
difficulty,
same since I worked there.
but their issues are similar to here: controlling cost, getting access, patients having access to healthcare. And you go to other European countries, you have the same issues in Italy, Germany, France. They have excellent healthcare, but like we are in this country, they're all struggling to figure a way to pay for it and to provide it in the most efficient manner possible. So it's you had mentioned Bill Rich. I had the privilege of getting to know Bill and learning from him about American healthcare. And so if you look at healthcare across the world, what do people want? So I think they want three things. They want high quality, they want low cost, and they want immediate access. The harsh reality is you only get to pick two. There's no system anywhere that provides all three. So in the UK, you have high quality, you have low cost, but you have significant access issues. And that holds for much of the European model. Here, I think in the United States, we have high quality, we have immediate access by and large, but we have high cost. So I'm looking forward to somebody figuring out how to give us all three of those. One of the problems that is becoming increasingly clear across the world is we're facing a physician shortage. So there's no country that has an excess of physicians. In the United States, you can pick which study you want, but there's we're going to be somewhere between 80 and 100,000 physicians short of what we need by 2035. And where that becomes increasingly apparent is that you often hear people say, well, there's 1 million physicians in the United States. And that's true. There's 1 million people with MDs or DOs, but there's only about 770,000 actively practicing physicians. And the really scary statistic is that approximately half of them are 55 or older. That's a problem, because if those, for whatever reason, if those doctors were to start retiring at a greater rate than they currently are, that's not replaceable. We only turn out 40,000 doctors a year, 40,000 physicians a year in the United States. Only 26,000 of those actually come from American medical schools. So the other 14 or so thousand are international medical graduates. And we have about 40,000 residency positions in this country. That's not enough to maintain the pipeline. So we need to increase the number of postgraduate medical training programs that we have. And that's becoming increasingly recognized. The question, of course, is who pays for it? Right now, the federal government pays for the vast majority of resident education, whether it's through CMS and their programs, whether it's through the VA. In ophthalmology, the VA trains about a third of the residents in the United States. So we have this impending shortage of physicians, which some people, and I happen to disagree with them, say, well, we can handle that by increasing advanced care providers. And I think there is a place for advanced care providers, and nurse practitioners, PAs, optometrists in our field. But that's not going to be enough. We need to increase the number of physicians in the United States, and we need to be able to do it in a way that's timely and cost effective. So we'll see where all that goes over the next decade, but that's one of my biggest concerns. The older you get, the more you realize pretty soon you're going to be on the other side of the fence. And I want the people taking care of me to be very well trained and accessible.
Right. And affordable. I know you don't care, but I do. So when you talk to people in general, do you encourage them to take on the challenge of interfacing with their local governments, or whether it's at statewide level or nationally? I know you're a big proponent of belonging to the AAO. The AAO has been, American Academy of Ophthalmology here domestically, has been an amazing resource for us. But even internationally, the societies that interface, are you a proponent of giving time to the societies, and how do you speak to that to people?
Yeah, well, my current job is I'm senior secretary for advocacy at the Academy. So basically, that is my job, is to convince, first of all, American ophthalmologists that they need to participate in our advocacy efforts. And I think we do a reasonable job, but we don't do a good enough job. So I know the details of how many of our members choose to contribute to our federal advocacy efforts. By contribute, I mean financially contribute. I know who of our members and what percentage of our members choose to contribute to our state efforts. And because I'm the current leader of those efforts, I often have the opportunity to speak with people about the problems that they're facing in their private practices, and how they often believe that the Academy is not doing what needs to be done, and they have ideas about what we can do better, and we certainly welcome those criticisms. I often find that the people who are most critical are the ones who have never participated in the process.
Isn't that always the way it is?
Yeah, that's just life.
That's just life, is exactly right. And so write the check, but give the time, equally important.
Yeah, I think that that's a good life lesson, is just give back. The easiest way to give back is write the check. The hardest way to give back is to give the time. But figure out a way to do one or the other. And ideally do both.
Right.
The greatest privilege we have as physicians is to sit across the chair from another human being and solve their problem. And in retina, it's just amazing the impact we can have on people's quality of life. You come into us with a macular off detachment, 95% of the time we're going to restore your vision and you're going to be good for the rest of your life. What greater privilege is there than that? But if you get involved in health policy and you can change the way healthcare is delivered, then you're not impacting one life at a time. You can be impacting tens or hundreds of thousands of lives at a time. So that's what drives my interest in health policy, is the opportunity to sort of change the big picture. And that's why I still enjoy it.
George, what a pleasure to hear your perspective. And on behalf of all of our listeners, let me just thank you for sharing part of your story and perspectives, lessons learned. And on behalf of the global retinal community, the American retinal community, and our local community here in California, thank you very much for all you've given to us and continue to give. I look forward to seeing you soon. And thanks again for participating in RetinaRounds and our Retinal Giants series podcast.
Well, thank you, Steve. It's really been fun having this chat with you, and I appreciate the opportunity.
Thank you very, very much. We'll talk soon.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.